The ACA Code of Ethics, in describing counseling relationships, indirectly refers to principles that help us respect the dignity and promote the welfare of our clients, which is the counselor's primary responsibility. These principles are really thematic areas of ethical practice. Justice, autonomy, which we've already discussed a little bit in relation to Sam's case, beneficence, and non-maleficence. And it's important to remember that sometimes these areas come into conflict, where you'll find one principle may trump another within a given dilemma, such as non-maleficence over autonomy. And we also may find ourselves attempting to balance our satisfying the principles across a number of areas within a given dilemma. The first principle we'll talk about is non-maleficence. And basically non-maleficence means to do no harm. And that's aligned in counseling with the Hippocratic Oath in medicine. We want to weigh the harms of our actions as counselors relative to the potential benefits. And there are also different kinds of harm. So again, in thinking about this principle, it asks us to mitigate adverse factors and conditions that can impact a client's well-being. In Sam's case, I'd like you to take a moment and perhaps jot down a few of the potential risks that exist for Sam. How could Sam experience harm in this situation? So one of the first areas that jumps out is his suicidal ideation. Another is potentially the adverse reaction that Sam is having to his medication. Antidepressants, we know at times, can trigger or make a manic episode worse, and that may be occurring in this case. Environmental risk for Sam relates to his possible homelessness. He also has a strained relationship with his primary care physician. And we know from talking a little bit about the ethical issues around interdisciplinary collaboration that if a positive relationship doesn't exist between the behavioral health consultant and the physician, that could in turn negatively affect the client's well-being in the primary care setting. Another area of potential harm for Sam is the fact that cognitive and emotional stress may negatively impact his diabetes and his coronary artery disease. We think about how do our interventions, how can they minimize the cognitive emotional stress, and in turn not worsen his medical conditions. Another risk may relate to having a white upper middle class behavioral health consultant and primary care physician who may not attend to cultural issues and inadvertently contribute to a sense of disempowerment that Sam may experience, especially as he is a member of a historically vulnerable demographic. With the important point, I think, here amongst all these potential areas of harm is that we at least think about them, we pay attention, and not overlook Sam's vulnerabilities. across the biopsychosocial spectrum. Because what we do not address, what we do not think about and integrate into our case conceptualization and our plan for collaboration may come back to really have some serious consequences for his functioning and well-being. So we want to be on the lookout for sins of omission with non-maleficence, and want to keep in mind, at the very minimum, we do not want to do any harm to Sam. So on the other side of non-maleficence, we have beneficence. And beneficence means actively promoting the good of others. So not only are we trying to avoid harm, but we're trying to maximize well-being. And to do that, we need to know what the patient views as good for themselves. And that involves knowing what their goals, values, preferences, and beliefs are. And that understanding can evolve over time. Beneficence is not solely measurable, for instance, by Sam's behavior in the primary care practice. So interventions that you may implement to increase his adherence and improve his cooperation and communication with the primary care provider only really tell half of the story. We usually only fully meet the principle of beneficence if the patient has and expresses a subjective sense that the helper is promoting their welfare. So I'd like you to take a moment and jot down some ways that you may best promote beneficence for Sam in this case example. So a few of the ways that I thought about where we can meet this principle is asking Sam, how can I best help you today? An open question eliciting his sense of what his needs are, and helping him express and perhaps prioritize what those needs are. So any attempts to summarize and help Sam clarify the problems that he's experiencing goes toward promoting his welfare. Another is expressing empathy. So empathizing with his stress and frustrations related to the healthcare system, and also his psychosocial stressors related to his job and distress regarding his home. In the process of doing this, if we're eliciting Sam's health beliefs, let's say it's my doctor doesn't get me or the system can't help me, we become better positioned to modify those maladaptive beliefs and promote beneficence from a cognitive perspective. Assessment is a part of beneficence, where we look at present and past coping. So an empowerment approach, an empowerment perspective, seeks to maximize patient self-efficacy, and that contributes to promoting Sam's welfare. Another way in this case of meeting this principle is involving Sam's family, if and when appropriate. So if we assess for his social supports, maybe there's a brother, or he has a parent, a friend who can be helpful for him in this time, then bringing them into a consultation if possible. We are sensitive to the importance of family, the relative greater importance of family and social environments for different cultures as well. So it's not just beneficence is not just sticking to an individualistic, westernized ideal of health and well-being, but it incorporates the social and cultural and environmental variables. Another way of promoting beneficence for SAM is seeking consultation regarding areas beyond your boundaries of competence. And we might want to do this, and one of the ways I've done this in the healthcare centers is consulting with the social worker who's on staff. And often they have a much better idea of what some of the state and city resources are for helping clients. Autonomy is the right to make decisions based on values, preferences, and beliefs. It's also the right to refuse treatment and to have privacy and dignity. Patients whose autonomy is compromised, we should really try to include them in decision making to the greatest extent possible. So take a moment now to think about how might you best promote autonomy for Sam in this example. So one possibility is assertiveness training, helping, and from an empowerment perspective, we can help Sam learn how to better communicate with his primary care physician in productive, cooperative ways, partnering ways. We can role play with Sam some of those interactions, whether it's related to medication side effects or general treatment goals. The more we can help Sam become his own best advocate, the more we are satisfying the principle of autonomy. We can also elicit from Sam and how he's coped effectively in the past, as well as what are his ideas for how he might go about changing his situation. Another avenue toward supporting autonomy is, after reviewing your role as a consultant, you might want to ask Sam whether he wishes to proceed. And, because potentially he may not want to speak with a mental health professional or a behavioral health consultant. And in fact, you can lay out other therapy options for Sam prior to seeking consent for participation in behavioral health consultation services. So Sam, may want to know that he can see a specialty mental health counselor for longer sessions, more frequent sessions. If there's if a group modality is something more along the lines of what he would be interested in, that can be presented as well. So we want to create a menu of options for Sam, if possible. Now, if coming to this other point about autonomy being compromised, and how do we work with patients when there are some questions about whether they can make decisions that are in their best interest. So if autonomy is compromised by a thought disorder, psychosis, suicidality, and we need to break confidentiality, we don't want to abandon collaborative practice at that point. So, Sam should be included in decision making to the greatest extent possible in those circumstances. So one of the things we might say to him, if we've gathered that he's in imminent risk of hurting himself, saying something like, as I had mentioned, when we started, I have a responsibility to make sure you're safe, and that sometimes involves letting other people know about what's happening with you. How would you like to go about letting somebody else know? What would your first choice be as far as who you'd want to reach out to, and how would you like to do that? Now, I certainly can do that for you, or you can do that. It's really up to you how you'd like this to work. So this is an example of continuing to include somebody in the process of a collaborative decision making, even when you are obligated to act in a specific direction. The next principle we want to focus on is justice. And in our clinical decision making, this refers to the fact that we want to maximize the likelihood that our decisions are fair. Fairness refers to the idea that society's benefits and burdens ought to be shared equally. It also encompasses the ideas that similar situations are treated alike, and that decision makers are both impartial and objective. And finally, that those affected by a decision should have a voice in that decision. So, for instance, when we talked about community-based participatory research with health promotion interventions, that was an example of explicitly designing a situation where participants in a health initiative have a say in decisions within that initiative as far as what type of interventions they're going to receive and how they're going to receive them, what will the content be, and so on. So taking this definition into account, take a few minutes and think about what parts of this case with Sam have to do with justice, and jot some of those ideas down. So one of the areas where justice may play into this case is we wonder if Sam's PCP has become negatively biased toward him as a result of previous stressful interactions. Would this provider spend as much time or more time with another patient expressing similar depressive symptoms and racing thoughts and describing similar psychosocial stressors, but somebody who happens to be less argumentative than Sam? Would that person receive a different kind of treatment, more of a positive or preferential treatment? In which case, the principle of justice would be violated. Another issue in this case that bears on justice relates to resources for Sam's potential homelessness. For those at risk of becoming homeless, we know that in Philadelphia, support is more easily obtained if there's a documented medical condition, which Sam indeed has. Being aware as a behavioral health consultant, in collaboration with social workers and finding out for yourself from city agencies, what are the parameters for obtaining support for the patients that you see, would be an important effort that contributes to an enhanced sense of justice and fulfilling that principle. Justice also applies to your work as a behavioral health consultant when you would respond with just as much compassion and autonomy support and empathy to someone else in Sam's situation. So we deploy that same sense of partnership, acceptance, and compassion no matter who we're working with. We make efforts to do that, and that feeds into justice. A broader justice-based issue with this case is you can understand if Sam had grown up in poverty and had a significant substance use history, resulting in unhealthy lifestyle behavior that worsened his diabetes and his heart condition, and as a result of that, I mean, this is in the hypothetical, as a result of that, if we can imagine that Sam's placing an increased burden on our healthcare system, we want to keep in mind that health inequities are often linked to pre-existing social inequities, and that efforts to correct social inequities necessarily will have some impact on health inequities. Advocacy is something that we have discussed previously, and we mentioned how it seeks to, when somebody is advocating for a patient, you're looking to remove barriers and obstacles that inhibit access, growth, and development. And advocacy efforts, as I already mentioned, occur at the individual, group, institutional, and societal levels, and that we want to obtain client consent before engaging in advocacy efforts. So I'd like you to take a few moments and again maybe write down some ideas about advocating for Sam. How might you go about that? Who would you involve, and what specifically might you be looking for? So along with this thought experiment, you know, just to add another dimension to it, you know that the social worker is a part of the integrated health care team. And so, again, with that in mind, how, as a behavioral health consultant, would you structure your advocacy efforts? A couple steps you'd want to remember. I've already mentioned asking permission to advocate for Sam, asking his permission, and also assessing his needs. So you might want to establish a hierarchy of advocacy needs, which, for example, might, at the top, the first one might be living situation stability. Next one, job search resources, finding support groups, maybe diabetes related or other health related support groups. Establishing who Sam's social support would be, but also are there opportunities to advocate for Sam within faith-based communities if Sam is religious. So those are a few of the ideas that I came up with. You might have some other ones. As you advocate, you certainly are supporting the principle of justice, and we should remember that these principles, beneficence, non-maleficence, autonomy, and justice, are often overlapping, and that supporting justice and autonomy also contributes to beneficence and non-maleficence. And there may be instances, as I had mentioned earlier, when one principle may trump another, or principles may come into conflict. So think of an example in this case for Sam, when beneficence and non-maleficence would come into conflict with autonomy. And what might you do in order to, as best as possible, maximize efforts in all three of those domains? So the process of informed consent and supporting autonomy really go together when you're using a framework of elicit, provide, elicit to go through that process. So thinking about just remembering the structure of elicit, provide, elicit, we're asking permission, clarifying information needs and gaps. We're providing information in a prioritized, clear, jargon-free manner. We're offering small chunks of information, followed by checking in. We're also acknowledging the individual's freedom to disagree or ignore the information that we provide. And we're avoiding the interpretation of meaning for the client. So we don't quite know how the information is going to sit with them and how it matches up with their past experiences. But we want to certainly then, in the third step, elicit what is their interpretation? How do they understand the information you've just provided? So what you'd like to do in this exercise is practice this elicit, provide, elicit format in orienting somebody to what panic disorder is. So you'd want to work in pairs or triads if you can meet in person in a triad or have a conference call. And this is a patient who has panic disorder but does not quite understand what that is. So your goal with this exercise is to offer psychoeducation around panic disorder, and at the same time be very cognizant of how you might support principles of beneficence, autonomy, and how you'd want to convey, use accurate empathy within those two principles. So this is an exercise that you can perform offline, and we'll pause here so that you can do that or reflect on that or kind of plan some of the steps you might use. So we've talked a little bit about the next situation in a previous class, but we haven't quite talked about it in relation to the four principles that we've just reviewed. So the situation, just to refresh your memory, is that from your training, you've read that SSRIs can sometimes trigger a manic episode. You're not sure if Sam's PCP is aware of the potential side effect, and from your assessment, Sam's meeting the criteria for a hypomanic episode. So the scenarios involves you seeing the PCP for feedback, and you want to raise this possibility. So what ethical domains apply to this particular situation of providing feedback and raising this possibility? How does justice play into this? Non-maleficence, beneficence, and autonomy. Ethical decision-making often occurs in the context of risk management. So in the next case comes from one of my own experiences as a behavioral health consultant in the healthcare centers here at PCOM. It involves a complicated case that spans 3 days, numerous ethical issues involved, involves 4 staff members, so 2 PCPs and 2 behavioral health consultants. And the chief complaints were suicidal ideation and marital stress. You should have these 3 parts within the worksheet that I sent to you, And what I want you to do is go through them and answer, in each part, answer the questions that they're asking based on your knowledge of the ethical clinical decision-making model, Kitchener's model, and also bringing in what you've known from your previous coursework in risk assessment and risk management. We're keeping an eye on interdisciplinary collaboration issues, as well as, when we're thinking about the different domains of intervention. So thinking about boundaries of competence, organizational pressures, advocacy, informed consent and confidentiality, and your role as a consultant. All those ethical issues, how would they play a part in this case within each of those parts? So take some time and complete that activity, and you'll be submitting your responses to that as part of this webinar. The principle of autonomy is captured really well within advanced directives. Advanced directives are very useful for individuals who can't speak for themselves, and they can make their healthcare preferences known and maintain independent decision-making if, again, they've lost that capacity through an illness or an injury. An advanced directive is a legal document. It can be spoken and then recorded by someone else. And as I had mentioned, it's a way to give consent for situations where a person may want or not want treatment. An advanced directive also can involve the appointment of somebody to make healthcare decisions, and that's often that person's often called a healthcare proxy, or a healthcare agent. A person has a better chance of having their wishes carried out, more control of those important healthcare decisions if they have an advanced directives. State laws often determine which family members can act in that capacity. So in Pennsylvania, it often the first person who has that control is the spouse, and if not the spouse, then adult children, and then parents, and then adult brothers and sisters. So there can be two types of advanced directives. One is a living will, and the other is the healthcare power of attorney. So the living will, as I mentioned previously on that slide, was it can be a document or it can be a verbal expression of one's preferences. The living will can also include extra instructions about healthcare decisions. So they can include do not resuscitate, conditions, organ donations, comfort care, whatever decisions that you would want regarding your care, if you can't speak for yourself. So what is a living will? A living will controls future healthcare decisions when you're unable to make decisions on your own. It can't cover all the situations that might happen, so that's why it's important to also have a healthcare agent, somebody who you trust to make some of those decisions for you. To be in effect, the living will, there must be a terminal illness or permanent unconsciousness for that will to go into effect, and it can determine, what is the extent of life-saving or life-sustaining procedures that are performed. Dialysis, tube feedings, artificial life support, treatment for pain and nausea is also part of the comfort care component of living wills, and as I had said, organ donation.
if working with your patients and describing advance directives and living wills, you want to communicate to them that they can revoke the living will at any time. They can change their minds about them. So it's not set in stone. The healthcare power of attorney, or the healthcare proxy, is somebody who can speak with doctors and carers on the patient's behalf. It decides that person decides which treatments or procedures you do or don't want. A few states don't allow your agent to stop artificial feeding. So each you want to advise patients to check with their state laws and regulations regarding that. The agent cannot be a doctor, nurse, or another person providing health care. So DNRs, again, can be added to the living will. There's two. There are two types of DNRs. One in the hospital, you can ask the doctor to add it to the medical record, and people may need new DNRs with each admission. Outside the hospital, DNRs are intended for the EMS teams, and they must be signed by both the patient and the physician. The Patient Self-Determination Act of 1990 stated that all healthcare agencies must recognize the living will and power of attorney. They must ask, every healthcare agency must ask a person whether they have an advance directive, and they also must give you information about your rights. So when we think about, just in general, we think about self-determination, advance directives are a part of maintaining a sense of autonomy and directing our lives, basically, if we're incapacitated. And so that's why it becomes really important in healthcare contexts to go over this, address this in consultation sessions.